There we go. Good morning. I'm Beth Trzanski. I'm the Deputy Director at Building Bright Futures. It's great to see everyone today. And this is our first, or a reset of this committee with the updated Early Childhood Strategic Plan. We are kind of reorganized what committees are needed to be able to monitor new goals, new priorities. And so, um, despite what the invite says, that it's formally known as the Child Outcomes Accountability Team, which was has had a lot of similarities, but we are shifting to call this the Goal 2 Committee, which is really focusing on the goal to language is all children are raised in safe, healthy, and healing environments. So the plan for today was that I was going to give you a little, like a mini orientation to the section of Goal 2 that relates to kind of health and mental health. And then we have some great guests to come and talk to us. The theme of this meeting is around kind of changes and challenges in the early childhood and family mental health sector. There's so many. We're only going to touch on three of them. And then we will to get some more information and then can open for discussion about what others are seeing, what are they hearing, are there emerging needs for policy recommendations? So that is our plan for today. Any questions before I pull up slides? All right, can be a fairly informal group. So I'd love seeing everyone's faces and please, introduce yourself in the chat so we know who is here, and ask questions as we go along. And if presenters want to hold on the questions until the end, that is totally fine. But as I share, I'll take a few minutes to share about policy recs or goal 2 and welcome questions. How's that sound for a plan? Okay. So I am getting my agenda. I can see you. Okay, here we are. Excited to be here. So this is our agenda, what I just walked us through. So let me, oh, and then I think the thing that I want to mention is going to take a few minutes at the end. We're going to try something new. And to be able to kind of ask for people to reflect on what are some themes that you've heard, things that we want to kind of record as emerging priorities or challenges, and that it will help BBF in our charge around advisement and monitoring of the strategic plan. So we'll see how that goes. So we have an updated early childhood strategic plan. This is the strategic plan that guides the state. This is not BBF's plan. This is the state's plan that guides for the next 5 years. We try and update it every 5 years. It's a very extensive process, but the ultimate goal is that every child thrives in a safe, healthy, and nurturing environments, supported by strong families, a valued workforce, and a coordinated system that puts children at the center. Oops. So these are the 5 goals that we have in the plan, and then I'm going to continue to get more specific. There was a lot of input to get here, but the first goal, we heard from families that meeting their basic needs and economic security was like number 1. That was the thing that they talked most about in our process update. So the first goal is all children and families have their basic needs met. And I am going to continue to let folks in. And then goal 2, which is what we're going to talk more about, is all children are raised in safe, healthy, and healing environments that promote healing and resilience. Goal 3, all children and families access high quality opportunities for development and learning. Goal 4 is around workforce. All children are supported by a well-prepared, well-supported workforce, and we're defining workforce very broadly. So anyone who's serving kids and families, from mental health to home visitors to educators. And then goal 5, our system centers families and is coordinated, well-resourced, and data informed and data driven. So that's like a little bit, that's your big picture of what is encompassed in the plan. Um, that's the new cover, super cute kid. The strategic plan is available online at that link on our website, and we will be printing copies. So we will get you copies if you like them. The process, there was a lot of folks involved. We engaged, over 200 families and providers, and many of you were involved in kind of providing input. So thank you. So let me just talk a little bit about governance and then can get into the strategic plan. And I am going to make one of my BBF team members a co-host so you can let folks in for me if you're okay with that. I'm managing too many screens. Kelly, if I can make you a co-host and you can let folks in. Thank you.
No problem.
All right. So what I talked briefly around what we talk about governance of the strategic plan. It's really who's tracking how we're doing, what progress has been made, what are the gaps. We are building policy recommendations every year. So we're making a shift for how we monitor goal 2. That the purpose is really to kind of track some of the issues that are in the goal, um, build cross-sector collaboration, which is huge in this goal. There's a lot in here. Membership is open. We really, as you can see, who's represented here, it's really cross-sector, and we will also rely on kind of the implementation teams or the groups that are doing this work in a more specific way. So I named just 3 of them, but like 350 Vermont around climate, or the CHAMP network, or the Family Child Health, coalitions. That there's already a lot of these groups that I think can aid in this work and provide input. This group is going to transition. We had been meeting every other month because of BBF capacity. We are a smaller team than we were last time this group came together. We are going to meet 4 times a year, which means a lot. We're going to have to be selective about what we talk about at these committees and really rely on getting information from you in other ways. I will be your contact. Katie Leffel is continuing on as the public co-chair, and we'll be looking for a private co-chair to help guide these meetings. How's that sound? Any questions? Okay, I see nods. So I'm just going to give you a few minutes to read through. So the goal 2 is split into 2 sections. And this first section is around ensure equitable access to comprehensive mental and physical health care from pregnancy through early childhood. I'm going to give you a minute to read through this slide. This is kind of like at the objective and strategy level, and would love to hear if you see yourself here at all. And so I'm just going to do about half of the goal that relates to our conversation today around mental health. And then we'll get into our little presentations and discussions. So take a moment to read this, and then we'll have a moment for reflections. I would love to hear from 1 or 2 folks. Where do you see yourself Where does your work is your work reflected in any of these kind of example strategies or in the objective law? Yeah, go ahead, Laurel.
Yeah, hi all, Laurel Oman, Director of the Child, Adolescent, and Family Unit at Department of Mental Health, and definitely see us reflected in here around the connection we have with the health department and the perinatal responses and support, and also the link with our Vermont Consultation Psychiatry Access Program. And then clearly towards the bottom of this list, the mental health treatment supports for the young children and their caregivers. So trying to make sure that we have evidence-based approaches and practices that will work for families that are accessible. Thanks.
Yeah, thank you, Laurel. Any other reflections on where you see yourself?
This is Anne at the CIS state team. I can see CIS in all of these things, but one thing aligns with a new focus. It's not new, but we're focused on it now, which is the ensure universal screening. We're just asking all the regions, CIS regions, to complete a survey about the screening tools that they use. And initial interactions with families and clients, and then as ongoing tools, and are exploring the use of social determinants of health tools. So, I think we have a pretty solid grounding in the developmental screening, but other areas of screening, we want to find out what is happening and what more we can do.
Awesome. Thank you. All right, I'm going to take us on to the next slide. There's a lot we could talk about, but I'm going to give you a minute to read this. So we're still talking about comprehensive mental and physical care. This strategy is specific to ensure family-centered, coordinated, and culturally responsive care. I know there's a lot here. I would love to hear from one or two folks if you see yourself and your work in any of these example actions.
Hi, Beth. This is Margaret. I'll jump in. I didn't speak to the last slide and certainly saw home visiting, in particular, the evidence-based home visiting as part of what was on that slide, and certainly more as well pertaining to this slide. We're really focusing on the integration and family-centered work. Certainly have spent a lot of time supporting culturally responsive care and will continue to do so in collaboration with trying to partner with doula services and just how sort of home visiting partners with doula and Dulce as far as coordinating care in addition to other CIS services.
Yeah, absolutely. Thanks, Margaret. Kaya and then Linda.
So I think I've done a lot of work in the anti-racism accountability sphere, and I would love to be involved as you're developing the framework.
Awesome. Linda.
Good morning. So in this slide, I see us in several places under integrate pediatric, physical, mental, and oral health for newborn or the Vermont Early Hearing Detection and Intervention Program. We're very involved in care coordination across for those infants that are diagnosed with hearing differences. I also see us in ensuring coordinated, equitable care across systems and culturally and linguistically appropriate services. And excuse me, and as well as the navigation support. I will say I struggled a little bit with the previous slide. Universal screening was listed, but it seemed to be specific around mental health. So just something to think about in the realm of newborn hearing screening as well as newborn screening in general.
Thank you.
You're welcome.
Okay, folks, I know there's a lot to talk about here but I'm going to move us on for the sake of time. So this strategy is specific to promote healthcare access and sustainability by investing in innovative service delivery. I'll give you a moment to take a look.
Beth, are you hoping we'll jump in, or are you just giving time for us to read?
Both. Go ahead. You feel free to jump in.
Um, Similarly here, I think it talks about Vermont CPAP, which we are trying to figure out sustainability for, the consultation service. And thanks, successful application for the PGG next, another year of award. We are looking for, we'll be putting out an RFP for consultation support around the early child and family mental health consultation to early care and learning sites. So just how do we structure that more effectively and efficiently here in Vermont so we can sustain it better?
Yeah, awesome. Mary Ellen, I see your hand.
Hi, I'm the director of the Early Childhood and Family Mental Health Program at Howard Center, and every screen reminds me of different things that we do. We, of course, provide mental health services that are across all settings, in homes, childcares, community, that are culturally sensitive. We also provide consultation, mental health consultation, and everything that's here is reminding me of all the different services and roles that we play. So it's very exciting.
Awesome. That's great. Thank you. I think there's one more, folks. Let me see. Yes. So let's take a moment to review this slide. And once you've gotten through, if there's something that speaks to you that you want to share.
This is Cheryl Wilcox from DMH. I'm going to be talking about certified community-based integrated health centers, but you will hear, like when I look at expand access to substance use treatment and recovery, and then also um, expanding access to crisis services and investing in staff. CCBHCs bring additional funding to agencies, and it also integrates substance use and mental health. So just a lot with that effort that DMH and the Health Department Division of Substance Use is making really supports a lot of these pieces and moves them forward.
Awesome. I said this was the last. I want to click to the next slide because I think there might be 5 strategies. Nope, I was right. Okay. Huh. So I know that there's so much in this goal, and really excited about who's around the table. Would also love some guidance around who you feel like is missing. Feel free to send me a message or put something in the chat because we are building this committee and identifying the focus. And no, we could spend every meeting on mental health, but we are really going to try and move around to other parts of goal 2 and also talk about how they are integrated. So that's what the work that we're doing. So any questions around the strategic plan in your like speedy orientation to goal 2?
Beth, I'll just ask a really quick question. If since this is a reset, sorry everyone, this is Cynthia. My camera's off today. um, because this is a reset for the plan, can you, if our work has shifted, right? Because now we have a basic needs goal, which is very
Yes.
exciting. And
Yeah.
I love the fact that this is broken out in more detail. But can you tell us how then, if our work has shifted from into a different goal, who is picking up, for instance, goal 1, or what does that shift look like in terms of that was all housed under the COPE committee, and so where is that work going, and do we know who's picking it up yet?
Yes, we will for goal 1, which is around basic needs. We are both going to have like a basic needs advisory group that will come together probably twice a year around kind of coordination and policy advisement. And then we are also relying on the many existing statewide groups and coalitions related to food security and transportation and housing. So we're also wanting to make sure that we're connected to those folks and advising because we didn't want to replicate any of those groups. Or duplicate. There was no need to do that. So I would say, Cynthia, hang tight. Michelle Kersey, who's on our team, is going to be taking point on a lot of that communication as she moves into a role in policy and data on our team as PDG, as the VECF winds down. And so we will be reaching out to you or just reach out to us and let us know that you would rather be connected to the goal 1 monitoring, which absolutely makes sense.
Sure, thanks. I mean, I want to be
Yes.
connected to it all, but I was just curious.
I know. Yeah.
Thanks.
Yeah. So we're kind of easy. We have new governance plan and easing into it or trying to figure things out in January. Any other questions on your speedy goal 2 orientation? Okay. I would love to move us on then. We have some fun guests today. So our hope was to get a sense of what are our key changes as well as challenges facing the early childhood and family mental health system in Vermont. So I've invited 3 folks to kind of give us a little bit of orientation and share some information and some framing around 3 different pieces. So we have Cheryl Wilcox, who's going to talk about the process for DAs to become certified community-based integrated health centers. We have Grace Johnson from to come talk to talk about changes to Medicaid billing for children with autism, and Maria Rossi is here to talk about impact of some delays on Medicaid funding on doula services. I know those are really big issues, so we will see how deep we can get. And again, like we're trying to get accurate information, but also be able to identify if there are kind of where the policy gaps are, and document that as well for in the strategic plan monitoring. So I'm going to have Cheryl go first because we have three big issues. I'm going to ask you to take 5, 8 minutes to kind of give us a little orientation. We can ask some questions, and I will try and keep track of time. How does that sound?
Lovely.
Okay.
Let me know if my share screen worked for you all.
Yes, seeing your screen.
Okay, lovely. So I will just say the transition to a CCBHC in Vermont is probably the biggest shift our designated agencies have had in decades. And so it's been fast moving and intense. And also, Laurel's been very involved. So, Laurel, as I go through, if there are things you feel like I'm missing specific to children's or whatever, please. But I wanted to get, and if you can't have your camera on, if you can put it in chat, just give me a read on knowledge about CCBHCs. That way I don't bore you or like talk the wrong amount. So 5 being like, yep, could rattle off that lovely long acronym, know what it means, know the services, to 1 being like, this is super new. Oh. Nice. Okay. That is really helpful. Thank you. So I sent these slides to Beth so that you all can get them, but there's also a website at the end that has way more information if you really want to dig in. But I know it's a short time, so I just wanted to give high level, like why we're doing this, what the status is, and then give more information so that if you want to stay informed or want to reach out, please feel free to do that. So also, about that. Folks can still see that, but hopefully it's bigger. Is that true? Okay. So so this is a federal certification. Like we as a state at the Agency of Human Services certify agencies as a CCBHC. And it is, there are lots of requirements at the federal level because this also comes with enhanced funding. And so it is a really great way to get more money into our system because there's enhanced federal match right now through 2029. And in that interim, we're looking at like how to sustain the funding. But at the federal level, you'll hear it Certified Community Behavioral Health Clinic, and Vermont changed the name. And it wasn't just because we like to rename things or be different. Although sometimes that's true too, we like to be different. But we've had a lot of feedback over the years that the term behavioral health is really stigmatizing. And behavioral health is used federally to talk about mental health and substance use. And many, many folks have said by calling it behavioral health, it makes it sound like this is a behavior. You can just change that. Like it's not a big deal, as opposed to like when you're really struggling with mental health and substance use, which this is about, there are a lot of factors in that. And so we didn't want to launch this and have a name that already was going to be stigmatizing and making people feel judged. So you'll see that that our name has changed. So in Vermont, the agencies that can apply for this certification are community mental health designated agencies or federally qualified health centers. I will tell you, no FQHC has applied to us to become a CCBHC. So it has been our designated agency system, and I'll show you the detail of where things are at with our different DAs. But it really has been a big process of agencies applying and saying that they will meet different federal standards. There's a different way they get paid and what they get paid for. So it's really been a strong partnership between us at Mental Health and then our Department of Health Division of Substance Use. So we've worked really closely. It's the clinical folks at Division of Substance Use. So the folks that are involved in recovery service organizations. So our different agencies that provide recovery services, and then also the clinical work around folks providing medication for alcohol use disorder, medication for opioid use disorder. So there's a strong clinical team at the health department that has been working with us. And for folks that have seen this, or you will see this, there's actually last Thursday, our secretary, Jenny Samuelson, presented testimony that AHS is making a recommendation to move the clinical piece of Division of Substance Use into DMH. Almost every other state has both in the same department, and in years past, they were combined and then they got separated. So there's already a bill on the House healthcare wall that combines the Division of Substance Use with us. And so we'll see where that goes through this legislative session, but just an important thing to know. But regardless of what happens there, this is a joint effort that we've been holding with our partners at the Health Department Division of Substance Use. So, like I said, I think some people have thought like, oh, CCBHC is just like a different way to pay, but it's the same thing. And it really isn't. And so what I would say is for the agencies working towards this, it is so intense in the work and the way that they're really re-looking at what they provide. There also are required evidence-based practices, so you'll see those. But there are these 6 program requirements, and I'm not going to go into all of the detail today, but it really is a piece of like, how are you coordinating better with your primary care providers? And it doesn't mean that hasn't been happening, but it has really clear, like there needs to be memorandums of understanding in communities between primary care providers of like, how are we going to make referrals back and forth? Or if someone goes to an FQHC, how does that work? The same with CCBHCs have to have peer specialists on staff that are providing mental health and substance use peer support. And we have recovery service organizations that have peer specialists for folks with substance use. And so that will be another MOU. It doesn't mean that every peer specialist supporting someone will sit in the CCBHC and be part of their organization, but it will mean that there's greater collaboration in the community to get people what they need. So this purple piece is an important piece of the scope of services. And these are the services that are required. And so you're going to see things on here that you're going to say like, yep, DAs are already doing that. And that is true. And the details beneath each of these are really significant and what needs to happen. So for instance, providing supports to veterans and family members of service members is something that every CCBHC has to have an MOU with our Veterans Administration down south in Vermont of how they will collaborate. And if a veteran or service member comes to a CCBHC and they need support, that people are more educated about what that means. Like, what does it mean to be in the military or be a service member? What kind of trauma do folks get if they're deployed? What happens to family members? Like when one of their family members is overseas or in a place that's dangerous. And so I think of our National Guard, like we don't have an active military base. So that means service members don't have that community that really is there if you live on base and you're around all people that are service members, people understand that. And so it really raises the bar for all of these, that being one example of how is there training? How are you knowledgeable? How can you ask the right questions when people come through the door? Because the other thing about CCBHCs is if you come through the door in crisis, regardless of your insurance or your age, you will be served for crisis. And then longer term services, if folks live, like if someone ends up in crisis in Brattleboro, but they actually live in Chittenden, like that CCBHC down south would provide crisis, would provide supports, and then would be referring back to the CCBHC that's in their region so that it really can be tied closely together. So I mentioned their evidence-based practices. I will say in Vermont, we have 10. We took a more conservative approach than some states that had 20 or 30. And then they found that people just could not keep up. So we have these, and we were really looking at the scope of whole age span, right? So children to adults, and then also substance use and mental health, suicide prevention. And it doesn't mean if you don't see something for children on this list, like parent-child interaction therapy, it doesn't mean that a CCBHC can't do it. They absolutely can. They can bill for it because they have the clinicians. It just wasn't something we were going to say, like, you will be required, because within all of these, there's also a lot of detail of the training staff are required to have and how they track that. So it really raises that bar. And then the same with cultural responsiveness. So really making sure that folks have training and are supported around making sure they have interpreters, they've translated documents, how are they making sure that people get the care they need based on their culture and needs. And then this is our timeline. So we became a demonstration grant last year, which what that means is that's the enhanced federal match we're getting for the agencies that become CCBHCs. We went live last July with Clara Martin and Rutland, so they are certified CCBHCs. And then we have 5 more agencies. You hear my voice, it's a lot, that are working towards certification by this July 1st. And this doesn't assume or mean that that will happen for all 5. Like I said, it's a really clear certification, and we have to certify to the federal level that if they're getting this enhanced money, they're doing the services as intended. But we are looking to be spreading all around Vermont. So we will keep working through certification and supporting them. We do have a website you can grab from the slides, and it has a lot more information. And then you also can always reach out to me. I'm presenting, this is a huge team effort at the Department of Health and the Department of Mental Health. So we have a lot of folks involved and are always happy to have questions come our way or folks that need more information. Thanks.
Thank you, Cheryl. On time. Nice job. So I know this is a massive thing. We have some folks from DAs here. Would love to, if you have reflections, or if there's questions, we can take a few minutes for questions.
I see Anne's hand and then Katie.
Hey, thanks so much, Cheryl. That was really helpful. This is a little weedy, I guess, but how does it work for a DA to go through these expansion of accessibility and all the things? Do they not get the additional Medicaid funding until they're certified?
Correct.
Or is there support as they build it?
It's a great question, Anne. So until they're certified, they can't draw down the rate the way it's set up. So that's one piece. And that's our certification. Like, we say you're certified, we tell our partners at CMS and SAMHSA, they're certified, they can draw it down. There have been SAMHSA grants, and SAMHSA is the Substance Abuse and Mental Health Service Administration. If I got that wrong, Laurel, tell me. We always just say SAMHSA. So there are some of these agencies that actually got expansion grants, which is like Clara Martin got one. It's $1 million a year for 4 years to help, because there's more data staff and more, like, as you can imagine, just doing the cost template, which is multiple tabs on an Excel spreadsheet so that we can set the rate. So some got them and some didn't. There were no grants last year, but more are forecasted to drop this spring for the next federal fiscal year. So we are hoping, and my guess is all the agencies working toward this would apply, because that's additional funds that flow to them to help them get structures in place. And there are some that don't have them, and they have just been so creative and amazing and working hard with staff they have to kind of like we've done honestly at VDH and DMH of like, what are staff holding and how do we kind of switch up what people are doing so that they can hold more of this work. And so agencies that don't have the grants are doing that, but we are hoping they all apply, and then we're hoping they all would get grants to help with that. So that's that piece of
Thank you.
the payments. Yeah.
Thanks. Katie, I see your hand.
I just had a quick question, which I saw the piece around integrating with the primary care and with perinatal people and birthing people, obstetrical services are often not considered primary care. So I wondered what is happening with connecting with obstetrical providers there, because one of the things we've seen over and over again with specifically treatment and prescribing during pregnancy and early postpartum with mental health, but also with substance use treatment, is that there's a lot of hesitancy around prescribing unless there's an obstetrician involved. And so I just was curious about that connection because I wasn't sure if they were being considered primary care for this, or if you can speak to that at all.
That's such a good question, Katie. It's so interesting. We've talked about primary care. It hasn't come up about OB/GYN. So I actually am going to take that question back and talk to some of our agencies about how they're doing that. There are also some DAs that have doula services. And even though doula service isn't in, you didn't see it in scope of services, the clinicians that provide those, there are codes they can bill for supports they're providing during that period of time. But I'll find out more about that. It's a really good question.
Yeah, and the Perinatal Quality Collaborative works with obstetricians and across the state. So if there's any kind of curiosity about engaging with like quality improvement efforts around pulling an OB or anything like that, they would be a great resource.
That's great. Thank you so much.
Yeah, great. Okay, we are at time to transition. So I know there's lots of other questions. Cheryl, thank you so much. That was very clear, and I certainly feel more educated about the process. So I really appreciate it. All right, Grace, I think we're going to have you go next. If you want to introduce yourself, if you have slides you want to try and share.
Yes, I do have slides, but I will start an introduction. Hard to follow Cheryl, who also stuck so well to the time. So I'm hoping I will be able to do the same. But
well, Grace, why don't I put a timer for like 8 minutes and I can just give you a heads up as we reach that, and then
that would be great.
Okay.
Let me see. I have not shared in Zoom before. I've only shared in Teams. So let me pull up. Let me see if this works. I think I can present it, and then you guys let me know. Can you see my screen? Okay, awesome.
Yeah.
So hi everyone, my name is Grace Johnson. I work as a policy analyst with the Medicaid Policy Unit at the Agency of Human Services. And I am here to really quickly give you guys an overview today of some of the changes that went into effect on 1/1/26 related to Medicaid reimbursement for applied behavior analysis, or ABA services. I will caveat that I've given this presentation many times, where it's usually a 30-minute presentation. So if it feels like I'm flying through it, it's because I am, but I'm happy to go back to any of it that I don't elaborate on enough, because I'm going to have to cut some of this. So just really briefly, I'm going to spend the least amount of time on this for this group, but on 1/1/26, we implemented some changes to what Medicaid reimburses, or how we reimburse for certain ABA services. And largely, the reasoning behind most of this has to do with the federal landscape and some of the vulnerabilities that our internal DVA staff identified when it comes to our federal partners and our federal funding. So I can dive into this more if people have interest in the questions, but essentially the OIG, the Office of the Inspector General at HHS, has included audits of Medicaid ABA programs in their work plan for the next few years. And basically what this signals to DVA is this is something that the federal government is interested in. It's something the federal government is looking at for states. It's something they're taking back and recouping money for from state Medicaid programs. And so when we see things like this pop up in the OIG work plan, we pay a lot of attention. And in response to sort of this addition to the work plan, we reviewed our own program and some of the findings of other states who had been audited by the OIG to really see if there were any vulnerabilities we needed to address. And so we noticed that the OIG had identified $18.5 million in overpayments in Wisconsin for ABA programs based on the allowance of concurrent billing of 2 codes without a policy in place. We also noticed that DVA, but prior to 1/1/26, had no written policy in place for the concurrent billing of those 2 codes. Based on similar fact patterns, this puts DVA at risk for an audit finding similar to the one in Wisconsin. So in order to sort of reduce our vulnerability and avoid an overpayment finding, we were forced to clarify our policy and align with correct coding by 1/1/26, which is now in the past. So there's 2 pieces to the changes that went into effect. The primary one is sort of this correct coding, the concurrent billing, which I'll talk about. I'll touch briefly on telehealth, and then I'll go into sort of what that means and what we're doing about it, which I think will probably be of more interest to this group than the nitty-gritty policy details of it all. But essentially, the concurrent billing of 97155 and 97153, which are 2 codes that are used when a licensed clinician and a behavioral tech spend the same hour with a patient, had previously been sort of allowed to be billed for the same hour, the same patient hour. And as of 1/1/26, DVA is now reimbursing for both the technician time and the licensed clinician time through just 1 code instead of 2. And essentially, that changes the billing from provider hours to patient hours. And largely, we rely on a couple different resources to make these decisions. One of which is the AMA CPT Knowledge Base 7744, which was released in December of 2023 and really specifically states that it's the patient's time face-to-face that's reported under those CPT codes and that both clinicians cannot report for the same unit of time. And so using sort of those guidelines, we went in, we created a policy, and it has now gone into effect as of 1/1/26. Largely, we had to do this in order to make sure that we were not subject to similar findings like in Wisconsin, and really make sure that if we were to be audited by the federal government, that we can, in good faith, say that we're working to address those vulnerabilities. So the removal of that concurrent billing is sort of that first big change. If you've heard about these changes, that's probably the one that you've heard about. The second big change was changes to services that'll be allowed via telehealth. And when I say allowed, I talk only about reimbursement from the Medicaid perspective. We aren't making any statements about what can or can't happen, just simply what we reimburse for. I understand the 2 are tied, but it is an important distinction. So our clinical integrity unit completed a review of existing research as well as consulted with licensed ABA providers regarding the practical use of telehealth for ABA services in Vermont, and largely has determined that a hybrid model for those CPT codes would be most appropriate. There are sort of 2 bodies of research, one which highlights the effectiveness of telehealth for children who have a baseline prerequisite skill level, and also an opposing body of research that really highlights how effective in-person treatment is for neurodivergent children. And so in determining which services would continue to be allowed via telehealth, we assessed different levels of usage and how they were being used, and really determined that there were some core services that DVA wanted to reimburse for solely when they were being provided in person. That includes sort of initial assessments, things that require technician oversight, and then other codes that may have been opened during COVID, but maybe are no longer clinically appropriate to continue providing those services via telehealth now that the world has sort of shifted back slowly to that sort of pre-COVID world. So those are sort of the 2 big buckets of changes. The projected policy impact of those changes: the Vermont Medicaid reimburses for 320 unique members. So that's the number of kids that we're talking about that have the potential to be impacted by these policy changes. As of right now, both our initial analysis and our continued analysis, we don't anticipate any loss of services for Medicaid members. So children who are receiving ABA services should continue to be able to receive ABA services. Providers will, on average, see a 12% decrease in the hours that are eligible to be counted into your payments. So for those of you who might not be aware, we reimburse for Medicaid for ABA services via a tiered payment rate. It's not fee for service. So it's the number of billable hours that puts providers into a tier, and then we pay out based on those tiers. So it's not direct one for one in the same way that fee for service is. That 12% decrease in hours eligible is very close to about a 12% decrease in reimbursement as well. You have some providers who will see a 0% decrease. You have some providers who will see up to a 16% decrease. Overall, based on the telehealth changes, 0.8%, so less than 1% of the total hours, telehealth and in-person for ABA will be restricted by limiting telehealth to that hybrid model that we're talking about. Of just the telehealth codes, 78% of those will continue to be allowed. So 78% of services provided in calendar year 25 would, if they continued in the exact same manner in 26, be unaffected by these telehealth changes. Many providers won't see a change to their telehealth practices at all. Only 6 of 20 providers who are currently enrolled with Vermont Medicaid to provide ABA services will see an impact to their telehealth claims. So it is a limited impact for those who provide telehealth.
And Grace, just to give you a heads up, that was 8 minutes. So I don't know
Perfect.
where
This
you
is
are
my
right
very
now.
last slide. We are all
Okay,
done.
great. Awesome.
So what we're doing in the future, we're just making sure that, we continue to monitor both our provider network and communications from members, reaching out to members, claims, to make sure that members still have access to medically necessary services. We're also currently conducting a rate study of Medicaid payment rates for ABA services. So this will make sure that we are reconciling provider costs and provider reimbursement to ensure provider sustainability. As with everything these days, we're not guaranteed that anything will lead to a rate increase because we have to get legislative appropriation in the budget. But we're hopeful that this will be able to give us some insight into whether or not these changes had an impact on providers and financial sustainability. And then just finally, we do have some members who've reached out to confirm that they're minimally impacted by the changes, and these providers have the capacity to take on new Medicaid members, which has helped us to ensure that if we do end up having providers drop from the network, that we have other providers who are able to see those kids and really reduce any sort of limitation of services. Okay, that was a lot. I'm really sorry I talked so fast to get through it all, but that's time. I'll end the slideshow, and then I'm happy to talk through any questions that folks have.
Thank you. Questions for Grace? That was a lot of information.
So I have a question. I know it said that 6 of the, I think, 23 providers are impacted by that telehealth change. Do you know what portion of kids they serve of that 325?
No, the exact number of kids. We do have the number, and I don't know it off the top of my head, Laurel.
Okay.
It's
That's
6 of
fine.
20.
And do you know
6
where,
of 20 providers.
are they in one region of the state, or are they kind of scattered around the state?
Good question. It appears from our initial analysis that they are scattered around the state. We do have a really great provider network, which is pretty evenly spread across the state. So I know that there are concerns about the Northeast Kingdom is an example that comes up often. Will these telehealth changes primarily impact kiddos who are in the Northeast Kingdom? And based on our conversations with providers, that's not something that we believe to be true at this time, but we're just continuing to monitor that to make sure that remains true.
Thank you.
Yeah.
Other questions for Grace?
Might be the easiest presentation I've had to do on ABA.
I know it's been a hot topic.
It has been a hot topic, yes, but we are hopeful that it will sort of even out, and we are working with providers to work through that rate study and to continue to get some more information. So we're hopeful it'll all sort of even out here in the next little bit.
Great. Well, super appreciate you joining us.
Yeah, thank you.
Yeah. All right, Maria, you're up next.
Thank you. I'm going to share my screen again.
Okay.
Can everybody see that okay? Is it in a slideshow like format?
We see the presenter, like we can see the slides on the side.
Oh, why I
So
can't.
it's not necessarily in presentation mode if you want that.
Well, I'm not seeing the presentation mode for some reason, so I'm just
Okay,
going to leave it as is in the
go for
interest
it.
of time.
That's
So
fine.
I apologize for that. But I know many of you. It's nice to see you. My name is Maria Rossi, and I coordinate the doula project, which is embedded in Washington County Mental Health. Cheryl talked about doula programs being embedded in designated agencies, and ours is the longest standing one. And we operate within our designated agency with some braided sorts of different kinds of funding. I'm here today representing the Doula Association of Vermont, who's been really involved in the Medicaid process for doula coverage. So I'm going to keep the presentation really focused on that. If anybody has questions about doula care or programmatic things, I'm happy to answer those later or another time or whatever. But in the interest of time and purpose, we'll just keep it really specific to Medicaid coverage. So this has been a multi-year process, close to 10 years. This was when this kind of started. We got a lot of momentum in around 2022 and 2024, I believe S109 passed. So I'll talk today a little bit about what that is and what happened. So this was an act related to doula services. It very quickly morphed into a directive to OPR and DIVA to undertake reviews of doula services and cost. This was something that was new at the time. We didn't know that this was necessary, but we quickly learned that it was inevitable to be going through OPR. So as probably many of you know, OPR, many of you are probably familiar with the role of OPR in Vermont. It professionalized many professions around the state through registration, certification, or licensure. At the time, the legislature directed OPR to conduct what was called the Sunrise Study, and that was really to look at the landscape of doula care around the country, what was happening, what were some of the limitations and gains that certain states had made, and elicited feedback from the doula community, from doula association, and from other stakeholders. That report can be found on OPR's website if anybody's interested in reading it. It was a very collaborative process. And we also learned that Vermont was really unique in utilizing OPR to professionalize doulas. In most other states, that's happening through like an agency of human services or Department of Health kind of way, and not necessarily a formal professionalization as OPR is doing. I'm hopeful that going through the OPR process is actually better for the workforce long term, but it does create a lot of additional things to do and a lot more work. So up until the end of the session 2025 last year, we were working, well, we still are working collaboratively, but up until the end of the session, we had a lot of support from DIVA. We were meeting with them regularly, and they had presented some payment structure based on what other states were doing. At the end of the session last year, they asked for an extension till 2027 and cited some political climate and some of the other roadblocks that I'll talk about. So they were granted an extension to 2027 at that time, which originally we were looking at coverage for starting July 2026, so like around the corner. And it got extended in May of last year to 2027. And we've since learned about some roadblocks. One of those being the SPA or state plan amendment and some of the risks around adding new providers to that. Some of it is limitations on how Vermont sort of does Medicaid under Vermont's waiver / global commitment. And then there's a political and social climate at the federal level that is impacting a lot of different decisions, as well as willingness to do certain things and ask for certain things from the federal government. So because of that, DVA has requested an additional delay legislatively until 2028. And OPR has followed because they can't really complete their work without the sort of tandem support of DVA. So that's where we are right now. And this is a very nuanced issue that is has a lot of complicating factors in it. And so the question really was asked to me, like, what does this mean for Vermont families and doulas? Those of you who are a part of BBF and some of you who have known about some of the work that we've done with BBF over the last couple of years, we spent a lot of time building our workforce in anticipation for Medicaid coverage. Washington County Mental Health, in partnership with NCSS, created a free statewide doula training. We had two cohorts of that. So we've trained over 50 new doulas this past year. So we're really concerned about losing some of that workforce momentum that we've built. The doula profession continues with lack of recognition or adequate compensation. And most importantly, families need perinatal support. And doulas are an evidence-based practice that addresses a lot of perinatal needs. And we have continued inequities. Families who can pay for access to doula supports privately will continue to pay for that. And there are parts of the state where there are doula programs. Here at Washington County Mental Health, we have the most comprehensive doula program in that we provide prenatal, birth, and postpartum supports. NCSS focuses on postpartum supports, and there are a couple of other programs that are just getting up and running with some support from some VDH grant funds. Vermont right now is really slated to be one of the last states that is going to secure coverage. People are surprised to learn that all but about 4 states are somewhere in this process. In 2026, we've got Louisiana and Montana, states that are traditionally more red are going to be passing coverage. And by the end of 2026, we also have pretty much all of New England is expected to start coverage this year, including Massachusetts, New Hampshire, and New York. So our neighbors, and Maine will be pretty closely behind them. I think that those of us who have been in the perinatal space also see doula care as a tool, as a potential early intervention tool. I know that's very much how we operate in our program, as well as addressing all of the health outcomes that we know that that doulas, people who receive doula care benefit from.
Marie, I think we're just at 8 minutes, just so you know.
Great. I have one more slide, and I don't need to really go through this. It's just so people know it exists. This is the Doula Association of Vermont that is working to represent doulas in Vermont. And this was sort of born from a national recommendation from the National Law Project that we've worked closely with around coverage. So I'm happy to take any questions, thoughts, concerns.
Thank you.
Maria, it's Laurel from DMH.
Hi.
Hi, I really appreciate your overview and your efforts on this, and I'm sorry it's delayed. It is a really tough context for all of this. So thanks for going over all that.
Thank you. It's not delayed yet. That's the
Sorry.
ask. And we
They're
do sort
talking
of
about
are like
delaying again.
operating under the fact that that very well might happen. But it is up to the legislature to grant DIVA and OPR that extension or not. I will be testifying later this afternoon. So we'll see.
Do you have any more of a sense of what the concern is with, and maybe this is more a conversation I can take offline with Grace, but opening the state plan amendment for these providers? Is it really just the context, the federal context, or is there more to that?
Honestly, there's been some mixed messaging. So it is a little bit tricky to nail down. I think that opening the spa, one from my understanding, and a lot of this is like piecemealing things together to like create an understanding. But is that really the issue? One of the biggest issue is the new provider. Isn't necessarily opening the spa, but opening the spa, requesting a new provider. So and Grace, if you're still here, correct me if I'm wrong or if I'm misunderstanding. And then the other sort of big issue, from my understanding, is about global commitment doesn't allow for direct payment to non-licensed providers, which is global commitment allows us to do a lot of other things, but that is a limitation of it. And I think some other groups are facing some of that same limitation, like recovery coaching, for example. But having recovery coaching or doulas, and I'm sure other providers being licensed isn't really congruent with the work and doesn't really make sense for a lot of different reasons. And actually, some states did pursue licensure in the early days of coverage and were very unsuccessful because it really wasn't the right match. And so we do have the advantage of looking at what other states have done, as we will be slated to be one of the last at this point. But that is something that has been explored in other states and really didn't go well, and they reversed course and did different things.
Yeah, Laurel, I'm happy to chat with you if you want. I think Maria touched on some important things. I think the concern with the state plan, as we've talked about, is like, it's not so much opening the state plan, right? We have to open the state plan for other things. It's that opening the state plan with a request that we know they're going to deny is not something we do. And it's also not a great look in the current climate. And it may lead to a denial earlier than we want. And like, if we ask for something we know they're not going to give us and they deny it, it's a lot harder for us to go back and ask for something that hopefully they'll approve. And so, as Maria touched on, it is not practice for CMS to reimburse for non-licensed providers. There are a very specific set of circumstances where that can happen. Usually CMS gives additional guidance as to what the qualifications would need to be for those people. There are pathways to reimbursement for doulas. It's just not something that fits into the current structure of doulas in Vermont. And so trying to mesh the current structure and what would be CMS reimbursable is not an easy task. And as Maria touched on, because Vermont loves to be different, we have our entire program under a waiver, which is sometimes really, really great. And also it means we act as the managed care organization. And so the requirements for what we could do are slightly different than for other states who might be able to offload some of that onto an MCO.
Thank you. That's super helpful.
Thank you, Grace. Any other questions, reflections? So we've covered a lot of ground today. Thank you for all the prep the presenters did and for folks' engagement. It's really great to hear and to have such great representation. I wonder if we can take a moment just to reflect on what we've heard and if we want to just, if people can popcorn it out, but like, are there themes that you're hearing around successes, challenges, barriers? Um, would love to hear kind of what folks are hearing in terms of themes or things that have stood out to you today.
I'll popcorn with a school district hat in perspective. I am I am continuously amazed by all of the like hard work, right, that our health department, et cetera, people put into this. Um, I'm really still doing the like, wow, where are we missing kids in this state and the complexity of providing all of the services that were talked about today in a geographic and transportation area state like Vermont. So those are just my initial reactions.
Yeah, thanks, Becca.
I'm just reflecting on the intersections of the presentations today and how things that feel really different are often not really different. Just in particular, I think Maria's presentation and thinking about the context of the first presentation and how those services uh, are interrelated. And I don't really have anything to say other than it's really interesting and exciting, but also so much connections to be made in the future too.
Thanks, Katie. Any other themes, observations?
It's all so complex. So yes, I echo that appreciation of the bits that everyone is working on towards the bigger system.
I also feel like there's this commonality. Like I learned so much, Grace and Maria, from your presentations, and I kept thinking of, again of those intersections of like, oh yeah, think about that for CCBHCs, and just that there's so much work to leverage our funding wherever we can, and then also having to think about the strategy of when and how we do that. And I feel like that's right the piece you talked about, Laura, of like how complex, because we're holding like we know what services and supports we want people in Vermont to be able to access. And then we have these other pressures. And then this additional layer at the federal level that I think, like, in my, like, just feel like there's a lot more strategy going on of like, how do we keep moving this forward? How do we hold this? How do we not lose hope and keep pushing forward? And it's very common. And so sitting in space and hearing these pieces of how we elevate the right work, how we leverage funding, how we don't put ourselves at risk of losing funding, like just um, it's just helpful to sit in a space where there's so much of that happening and people navigating that.
Feels like a team Jenga, right? I'm going to poke at this one and let's see how it affects the others.
Yeah.
But
Yeah.
yeah.
And we don't always see those connections or interrelations. So I do appreciate spending time there. Fabulous. All right. Well, again, thanks for all of the work and the engagement. I know some folks had to drop off, but given what we were trying to accomplish today, I'm really appreciative. I am going to set up a new calendar invite for this group. I would say if there are changes to who from your team might be attending, or if there's folks that you think are missing, please let me know. We are scheduled to meet in March. This group is planning to come together 4 times a year, but I'm not necessarily going to spread those out equally because of when people's availability is. It feels like that cadence is going to work best. So I'm going to set up a new calendar invite and try and capture some notes. And if there's any other follow-up question or you have any resources you want to share, please send them along. So thank you all. Really appreciate it.
Thanks.
Thank you.
Thank you.